Assalamu alaikum and a very good evening to everyone. I'm Dr. Azhar Rahman, consultant anesthetist from AKU. Um, I welcome you on the platform of PSA Karachi. Today we have Dr. Tanveer Baig, who will talk about the anesthesia concerns for meningomyelocele, a very important topic, not only from the examination point of view, but it is very important from the practical conduct as well. Dr. Tanveer Baig, he is currently working as a consultant anesthetist and assistant professor at Aga Khan University Hospital, Karachi. He has a wide experience of anesthesia, expands over more than 25 years. He has been working in the anesthesia department in AKU for the last more than 10 years, more than a decade. Before that, he worked in KSA as well. He's an examiner of CPSP anesthesiology, and he's a pertinent pain physician as well. So I welcome Dr. Tanveer. Meanwhile, I will request all the participants to please keep their mobile phone on the mute mode. And if you have any question, please write it down in the chat box. At the end of the this presentation, a link will be shared in the chat box. You have to fill that link in order to get the certificate. Dr. Tanveer.
Thank you, Dr. Azhar, for my kind introduction. Uh, Today, topic of our discussion is anesthesia concerns for meningomyelocele patients. So, what is meningomyelocele? Meningomyelocele is a congenital condition in which the spinal canal actually does not close at the time of birth. It's a type of neural tube defect, and it usually start at the 4 week of the pregnancy. It's characterized by incomplete neural tube closure, which usually filled with uh, CSF and layered with meninges, and it's usually protrude from the back. As you can see, what this picture depicted is the spinal cord fibers are coming down, and through this hole, the nerve fibers are coming out and having a pouch which contain cerebrospinal fluid and layer of meninges. On down this finger, you can see this is this protuberant structure is actually myelomeningocele. So it's usually associated with the or present like a patient present with hydrocephalus and sometimes with motor and sensory impairment and bowel and bladder dysfunction. And it's usually associated with Chiari type 2 malformation. Chiari malformation, as we go in detail, is there are 4 types of Arnold-Chiari syndrome, and usually type 2 is usually associated with this meningomyelocele presentation. Type 1, if we'll go through it, that cerebral tonsil usually extend into the upper spinal canal, and symptoms can appear in infancy, childhood, and adulthood. It can be caused by a skull if too small or misshapen. Because of that, you may get type 1. In type 2, usually cerebral tonsil and brain stem extend to the upper spinal canal, and it's usually associated with the spina bifida, mean spine is opened, and it usually cause headache, hydrocephalus, and sleep apnea. In type 3, cerebellum and brain stem usually extend back from the lower part of the skull, and in type 4, the cerebellum is underdeveloped and incomplete. So type 2 Arnold-Chiari syndrome usually associated with meningomyelocele. Through this picture, we can uh, get into it. Like normal structure, you can see the cerebellum is here, midbrain is descending through the spinal canal like that, and its structures are in the calvaria. And if you will go here in this picture you can depict it, that downward placement of the cerebral tonsils are here. And in type 2 you can see the midbrain and part of the tonsil is just going or descending down. So if we go through the neurological structures and a structural concern, why we are going for surgery for this meningomyelocele patient, like it usually causes spinal cord damage. And why? Because the spinal cord is exposed and vulnerable for injury, and we have to take care while intubating the patient because these parts are exposed. Ultimately, this spinal cord damage or this injury to the spinal cord leads to the impaired CSF drainage also, which leads to hydrocephalus. That's why uh, VP shunt is sometimes very much necessary to control the hydrocephalus, and ultimately it may leads to the theatered cord syndrome because some fibers of the nerves, they get attached or entangled in lateral canal, which leads to neurological damage or leads to bowel or bladder dysfunction also. So what would be our preoperative evaluation would be? Like thorough assessment of patient neurological status should be there, and airway is very important, and other associated anomalies should be addressed, like cardiovascular issues we can found it, like some few congenital abnormalities, heart disease are associated with this disease. So preoperative evaluation we should consider cardiovascular issue, renal and bladder function. We can assess bladder if patient may have neurogenic bladder or may present for some renal abnormalities also. These patients are more prone to develop meningitis also, so risk of infection is there. So prophylactic antibiotics should be started before going for surgery. Then anesthesia consideration, like positioning is very important. As you know, the part of the spine or some cavity or some portion is exposed, so it's very difficult to position that baby also. So positioning during anesthesia while intubating the patient is very important, because then we have to have or we have to put some gauze surrounding that area to avoid pressure on that balloon like structure. Airway, of course, it's difficult to manage airway in this kind of patient because positioning is very important. Then sometime you have to have in hands to get position for good airway management. Then another important thing is hemodynamic instability. So maintaining a good blood pressure is vital for these patients because hypotension may lead to further neurological damage. As neonates, more prone to be hypothermic. So in these meningomyelocele patients, it's very important to have a ideal temperature in or room temperature should be ideal for neonates or infants in the OR. Then fluid management is very important because you may get the baby of 3 or 4 kg. So initial 4 kg, 4 mil per kg body weight. So you have to have replaced full NPO fluids, and then maintenance fluid should be through the buretol or through the 10 or 20 cc syringes to avoid intraoperative hypertension. Then these patients are more prone to develop bradycardia also. So in spinal cord manipulation should be, I mean, very carefully done. Then these patients are more prone to develop respiratory depression also. So very close management of inhalational analgesic agents should be there. Other anesthesia consideration, like we have to control the intracranial pressure, because a small maneuver positioning of the head may raise intracranial pressure. And another important thing is autonomic dysreflexia may be there in these kind of patients, because if slight pressure on the nerve fiber, or sometime these meningomyelocele arises from the upper areas, then autonomic dysreflexia is more common. Then another important thing is loss of sensory and motor function. It depends on lesion level. If lesion is more cephalid, then loss of sensory or motor function would be more there. Then another important thing, consideration of the position also, like pressure on that opened spinal cord should be avoided, and should be covered properly, and should be cushioned properly to prevent further injury. Another important thing, while we entangled or busy in uh, meningomyelocele surgery patients, like intraoperative neurophysiological monitoring. Intraoperative neurophysiological monitoring is very important in meningomyelocele patient to uh, prevent neurological damage and to prevent bladder and bowel function destruction. Like neuromonitoring, it helps to minimize neurological damage, and it's usually help in getting that if we are very near to some crucial structures, then we should avoid that structures should not be damaged. The key points about neuromonitorings are modalities are like somatosensory evoked potential SSEPs, motor evoked potential MEPs, and electromyogram. Electromyogram is to detect electrical activity in muscles, and it's give information about the nerve root function. Motor evoked potential usually give motor pathway function, and it's stimulated through the band, and recording through the muscle will be done. Somatosensory evoked potential is assesses the sensory integrity by stimulating the skin and getting response recorded through the machines. The benefits of these monitoring is early detection of potential neurological complication, ability to make immediate adjustment to minimize neural damage, and increase confidence in preserving neurological function. And the considerations are required specialized expertise in neurophysiological monitoring, may not always accurately predict post-operative neurological outcome, and can be affected by anesthetic depth and muscle relaxation. Positioning and skin integrity. Spinal deformities like sometimes slight scoliosis is may be associated with meningomyelocele. So positioning is very difficult for these sort of patients. Then proper spinal alignment is very essential. Then risk of pressure ulcer would be there, because these areas are very fragile. So we have to take care properly for these pressure source. In post-operative consideration, pain management is very important, because sometimes altered sensation below the level of lesion complicate the pain control, because we may get that maybe pain is not there, but sometimes it usually involves nerves of the lower limb also, but we have to uh, use opioid cautiously because of uh, reason of respiratory depression, and sometimes regional anesthesia. But in our practice, we have no have any experience of regional anesthesia. Post-operative ventilation, some patient may have respiratory muscle weakness, particularly Charlie malformation type 3, and these kind of patient may need ventilatory support after immediate post-operative period. Key points for anesthesiologists, like Very important point is ICP management, regular monitoring, especially with hydrocephalus and VP shunt maneuver. Then spinal cord protection, careful positioning to avoid further injury to expose spinal cord. And then important point is autonomic dysreflexia should be controlled properly. In summary, multidisciplinary collaboration is very important. Anesthesia management for meningomyelocele require careful planning, coordination, and other specialists. And vigilant monitoring, continuous monitoring for ICP, airway complication, autonomic dysfunction, and neurological deterioration. Customized care is very important, like anesthesia technique should be tailored to specific needs to each patient based on the severity of the condition and comorbidities. Thank you very much. If you have any question, you can write down and link, and we will try to answer your questions.
Thank you, Dr. Tanveer. Dr. Faraz Shafiq is also with us, who is the director of the neurosurgical anesthesia. I will request Dr. Faraz, please comment if you have any comment. Dr. Faraz.
Thank you, Dr. Azhar, and thank you, Dr. Tanveer, for such a wonderful presentation. So I think Dr. Tanveer has already explained things, in a very precise and a clear way. So it's very important that, as Dr. Tanveer already said, that individualized care needs to be given to these patients. So it's important for us to understand the pathophysiology, the need of the surgery, and more importantly, as it was discussed by me also in the first lecture of neuroanesthesia, that all these kind of cases needs to be discussed with the neurosurgical team, because expertise would not be the same for every neurosurgeon, the team, the support available. So before the start of the procedure, for all the cases, especially I'm talking about neurosurgical cases, though it's relevant for other surgical procedures also, but specifically for the neurosurgical patient, case needs to be discussed and planned post-operative care needs to be, planned actually. So that is all from my side. Yeah,
Thank you,
thank
Dr.
you.
Faraz. Dr. Darshna is also with us from Ireland. I will request her if they are doing the neuroanesthesia over there, please, would you like to throw some light on this? Dr. Darshna?
Hello, Dr. Azhar. How are you?
I'm fine. I'm fine.
I'm good. The hospital where I'm currently working is not doing the melangocele. Is only in the pediatric hospital. They are still doing. They are doing it, and is more kind of a diagnosed early with all that. As Dr. Tanveer mentioned, the same concern, anesthesia concern, which we have. So it's more kind of a now monitoring available along with the BIS monitor. You can check the cerebral perfusion pressure and everything with the same BIS monitor recently, which came to our hospital as well. So it's a combined monitor where you can check the cerebral oxygen saturation along with the BIS and EEG at the same time.
Darshana,
For this,
nowadays neurosurgeons in US, they are doing intrauterine spine surgeries also.
yeah, that's what I'm saying. Like it's all depends. Everywhere has the. It depends what you have the things available. So that's the different thing only in terms of monitoring, but the technique is the same for the post-op and intra-op. Hello, can you hear me?
Yeah, we can hear you. Thank you, Dr. Darshna, for your kind comments. Um, there's a question in the chat box by Dr. Shahid Dar. He is interested in knowing, will you prefer intubation in lateral position or some role on back to handle meningomyelocele?
I think the ideal way is to you have to have one good assistant, which who should hold the baby in a way that you can manipulate the neck position also, and with other hand, that meningomyelocele part should be covered by gauze and with one hand. So usually it would help in intubation. Otherwise, lateral position, we can go for intubation also. But if good assistant or colleague anesthetist, if help you, it would be mean more easier if you are handling with two hands.
Okay, thank you. Very often we do the caudal blocks in patient who are coming for some other surgery. So if the patient is having teething, is there any condition in which patient goes unrecognizable, and if we put the caudal, it may damage the nerves?
Azhar, it's a very good question. The thing is, if teetering is there, so there must be a history of surgery there, or some small hole or some rent must be there. So caudal anesthesia should be avoided, because as you know, as I showed in pictures also, then nerves would be entangled in that portion also. So there is no point putting a caudal in these type of patients.
Thank you. So what is your usual practice after meningomyelocele repair? Do you extubate the patient, or do you send the patient to neonatal ICU? And the second part of my question is that how you maintain the temperature in neonates, because they cannot create they don't have the function of auto generation of the heat.
Yeah, Azhar, it's a very valid question. Really, the thing is, you have to cover all four limb with the cotton, then with some foil. So you don't want convection of temperature to the environment. And then other thing is, you have to have warm fluid, warm theater, warm hand, and properly covered. So that's how you maintain the core body temperature of the neonate. And another thing is, usually decision should be taken for taking to the ICU or not. If some comorbidities are there, if neonate's body weight is like that, less than 4 5 kg, and respiratory muscles are very weak, then obviously you have to have ICU for these kind of patient. Or if patient is weight wise and other things are, or comorbidities are not there, then you can plan for extubation also. Even then, patient should go to the ICU.
Yes,
Thank you.
Dr. Azhar.
There is another question. Uh, Dr. Maksud wants to know the ideal drugs for induction and intubation.
Ideal
Doc-
drugs, yeah. Ideal drugs, usually for babies, we are starting with induction with sevoflurane. If IV line is there, we can go for minimal small dose of propofol also. But in our practice, we are usually starting with sevoflurane, then IV line, and
Oh.
then we
So
can.
sorry to interrupt you. May I know the reason for starting with the sevoflurane?
Yes, sevoflurane is a good inhalational anesthetic agent, and without sevoflurane or without induction, how you will get the IV line? Because it's very difficult to have a IV line also.
Okay. So if there are no
Dr.
more
Azhar.
questions, yeah,
Dr. Azhar.
yes.
So regarding three important questions you have asked to Dr. Tanveer, so Dr. Tanveer has already answered, but I just want to add my comments also. So regarding the temperature stuff, so it's very important that you should start controlling the temperature before the induction of anesthesia. So right when you take the patient into the OR, so it starts from the increasing ambient air temperature, and then as Dr. Tanveer already told that you can use the devices whatever is available to you, bare agar, and on the top of that you can have the cotton and the foil also. Besides, the second thing about the need of post-operative ventilation, it all depends upon the surgical skills, the complexity of the procedure, and more importantly, for kids having age of less than 1 year, you need to look at the airway edema, especially in the prone positioning. So, if you'll anticipate the things like duration, the complexity, and airway edema needs to be looked at, objectively at the end of the procedure before taking the decision of sending into the ICU. So these are the two important things: the duration and the airway edema, which is quite common in the prone positioning and for a procedure lasting for around 4 to 5 hours. So one should be expecting that. Regarding ideal anesthetic agent, it all depends. The need of the need of the time there. For say, if you don't have IV line available, then definitely you have to go for the inhalation induction. And otherwise, yes, if you have got IV, so better to be relying on opioids and in a combination of inhalational and yeah, low dose propofol for the induction agents. So that was from my side. Thank you.
Thank you. So there is a question by Mahmuna Sheikh. Some case reports of giving a spinal for meningomyelocele repair. Please comment or share your experience, especially LMIC setup or peripheries with very limited resources. Dr. Tanvi?
Yeah. I think as a for limited resource setup, we can go same like what we are doing. Like we can have, temperature we can maintain in the theater, blood calculation we can done in low MIC setup, and
No,
inhalation.
actually, she has come across some case reports regarding the spinal anesthesia for giving spinal a neonatal case under spinal anesthesia.
Rightly, as we have no experience of spinal anesthesia and neonatal, especially in meningomyelocele patient.
And I
Yeah.
think the guidelines does not recommend giving spinal in neonates because of multiple factors. Even with the spinal, you need to have secured the airway because neonates cannot cooperate just like adults do. Another thing, it's the dose. It's very sensitive to give the spinal to neonates. A fraction of drug increase may end up in a disaster. So it's better not to deviate from the standard practice. There are so many case reports you will come across. People are doing the unsafe practice, so it is not to follow it. It's better to
Yes,
avoid.
yes, I think for low middle income countries like us, better to have general anesthesia. I think there is no need of doing these kind of heroic measures.
So I think there are no further questions. Thank you, Dr. Tanveer, for sparing your time, and thank you, Dr. Faraz, the Dr. Darshana, for your input. Um, Thanks a lot. We'll see you again. Till then, Allah Hafiz, have a nice day ahead. Thanks, Shujat Ali, for your support. Thank you.
Thank
Thank you,
you.
Dr. Azhar, and thank you, Dr. Tanveer.
Thank
Allah
you
Hafiz.
to all.
Thank you all.
Thank you.